السلام عليكم جميعا. إن شاء الله هنتكلم النهاردة على disorders of head size. Disorder of the head size may be large sized head, what's called macrocephaly. The definition of macrocephaly means that the head circumference is measured 2 standard deviation above the mean for age and sex, or above the 95th percentile for age and sex. If you are going to measure the circumference, and then you will use the standard deviation curve, you plot the head circumference in centimeter against the age and sex of the patient. You will find this 2 standard deviation above this, or it is above the 95th percentile for age and sex. What about the causes of macrocephaly? Number 1, the causes may be in the brain itself, what is called megalencephaly, which may be benign or familial or secondary, or increase the cerebrospinal fluid inside the ventricular system, what's called hydrocephalus, or enlargement of the vascular component like arteriovenous malformation, subdural, epidural, or subarachnoid or intraventricular hemorrhage, or increase in the bony compartment of the brain. It is increase the size of the skull, as in the thalassemia major or achondroplasia, or miscellaneous causes like cyst or abscess or tumor. Number 2, the microcephaly means the head circumference that measured is more than 3 standard deviation below the mean for age and sex, or below 3rd percentile for age and sex. The types of microcephaly may be primary, called genetic microcephaly, or secondary non-genetic microcephaly. Today we are going to discuss a very important subject, the hydrocephalus. The objectives of this lecture is to know what is the hydrocephalus, what is the etiology of the hydrocephalus, what is the clinical picture of the hydrocephalus, and how to diagnose the hydrocephalus, and how to treat the hydrocephalus. Hydro means water, cephalus means brain. It means there is excess water in the brain. First of all, we have to know the anatomy and physiology of the CSF. The CSF is formed by the active secretion of the choroid plexus in the ventricular system, 25% formed by the capillary endothelium of the brain. The volume is about 15 milli in infant and 150 milli in adult. The CSF is turning over 3 times per 24 hours in a continuous circulations at a rate of about 0.35 milli per minute. The average pressure is very important. We need to know the pressure in the ventricular system. The normal pressure is about 90 to 180 millimeter water, whereas in the sinus pressure it is the half of this, about 90 millimeter water. 90 millimeter water. The CSF is considered a source of sodium, chloride, calcium, vitamin B, and insulin growth factor 2, and the other trophic substance for the brain. The CSF is a sink to harmful proteinaceous material and catabolites. The adrenergic decrease the CSF production, the cholinergic increase the CSF production. What about the function of the CSF? The CSF is considered as shock absorber. The brain float inside the CSF. There is micronutrient transport inside the CSF like vitamin C, folate, vitamin B6, desoxyribonucleoside, and trace element. the CSF removes the metabolites and the catabolites from the brain cells. The protein and the peptide supply inside the CSF. There is a buffer reservoir for the CSF. It is a volume for dilutions, reductions in the acid in cases of ischemia, and the potassium in cases of seizures. One of the very important functions of the CSF is his role in the immune system. It is responsible for the immune system mediations, antigen-presenting stimulated proliferation of the T helper cells. It is the source of the drug delivery to the brain. The endogenous protein carrier inside the CSF deliver the drug to the CNS. So, any drug have high penetrations in the CSF is considered a very useful drug used in treatment of any CNS disease. What about the circulations? You look here, the CSF formed by the choroid plexus in the lateral ventricle. Then the CSF escapes through the foramen of Monro to the third ventricle, and then to the aqueduct of Sylvius, to the fourth ventricle. The CSF escaped through the foramen of Leschka and Magendie, present in the roof of the fourth ventricle, to the subarachnoid space and the granulation. Subarachnoid space which contain subarachnoid villi and the granulation, and then escape to the dural sinuses. What about the definitions of the cerebrospine of the hydrocephalus? The definition of the hydrocephalus is dilatation of the cerebral ventricles due to excessive accumulation of the CSF inside the ventricular system, due to mismatch between the secretion and preabsorption. We classify the hydrocephalus into relative, there is secondary to brain atrophy, and the pressure is not increased, it's called normotensive. Absolute, and this is associated with increase in the CSF tension. What are the causes of hydrocephalus? We classify the hydrocephalus into two main groups. Type 1 is the communicating hydrocephalus. It means there is communication between the ventricular system. Ventricular system communicate with each other. This is due to excessive formation of the CSF from the choroid plexus in diseases like papilloma, choroid plexus congestion in cases of meningitis. Or there is impaired absorptions caused by adhesion or leukemic infiltrate in the subarachnoid space and sinus thrombosis. Type 2 is the obstructive non-communicating hydrocephalus. It is the most common one. It is called type 2. The ventricular system does not communicate with each other. The most common cause of obstructive hydrocephalus is obstruction of the aqueduct of Sylvius, and this may be congenital or acquired. The second most common cause for obstructive hydrocephalus is obstruction of the foramen of Leschka and Magendie, and this may be caused by congenital causes like dento-Walker malformation and Chiari malformation, or maybe due to acquired causes. The obstruction of the foramen of Monro is the third most common cause for obstructive hydrocephalus, and this may be caused by congenital causes or acquired causes. The obstruction of the aqueduct of Sylvius may be congenital stenosis, and this congenital stenosis may be sporadic, or sometimes it is X-linked recessive trait, so there is family history of hydrocephalus. Or may be acquired by gliosis, the injury of the brain healed by glial tissues formation, so it is called gliosis, not fibrosis, like in the meningitis, subarachnoid hemorrhage, mumps meningoencephalitis. Or maybe space-occupying lesions, like congenital aneurysm compressing the aqueduct of Sylvius. The most common one is the aneurysm of vein of Galen, or any AV malformation or cyst or tumor or abscess compressing the aqueduct of Sylvius. This is the T1 MRI And the right one it is the normal, and the left one is the pathological, showing dilatation of the ventricular system, the frontal horn and occipital horn of the lateral ventricle, and there is dilatation of the third ventricle, so the obstruction is above the aqueduct of surface. The other picture is the normal one. The second common causes for obstructive hydrocephalus is Dandy-Walker malformation. In the Dandy-Walker malformation, there is ballooning of the fourth ventricle due to atresia of the foramen oblongata and Magendie, which is the exit of the fourth ventricle to the subarachnoid space. This may result from developmental failure of the roof of the fourth ventricle during embryogenesis. The patient comes with macrocephaly and occipital protuberance, which is very prominent. Another congenital anomalies may be associated with Dandy-Walker malformation, like absent or hypoplasia of the vermis, which connecting the two cerebellar hemispheres, total or partial absence of the corpus callosum in 60% of the patient. This is the CT finding of a patient with this abnormality, showing the posterior fossa is totally occupied by the CSF due to ballooning of the fourth ventricle. Arnold-Chiari malformation type 2, another example for obstructive hydrocephalus. There is elongation of the fourth ventricle due to failure of the pontine flexure during embryogenesis. So there is lengthening of the vermis, bones, and the medulla with downward displacement into the cervical canal. So there is progressive obstructive hydrocephalus. This patient usually have a stridor in 10% of cases, weak cry, and apnea in infancy. Always associated with lumbosacral meningomyelocele. Lumbosacral meningomyelocele means that there is another congenital anomaly affecting the vertebral column elevation, so there is defect in the vertebral arch to be formed, so the cerebral meninges escape containing CSF, it's called the meningocele. If it is containing spinal cord, it's called meningomyelocele. The meningomyeloceles may be lumbosacral or dorsal or even cervical. And this diagram illustrates the Arnold-Chiari malformation type 2. There is downward displacement of the brainstem, taking the cerebellum, obstructing the subarachnoid space. What about the clinical picture of any patient come with hydrocephalus? The hydrocephalus may occur in infant, so there is symptoms in infant, or may come after closure of the anterior fontanelle, so there is another clinical pictures in the children. The clinical picture, symptoms and signs in infant: the head is larger than in normal size, it's called macrocephaly. There is high-pitched cry, poor feeding and sleepiness, bulging white fontanelle and displayed sutures. There is sun-setting appearance. Normally, the upper eyelid cover the upper 1/6 of the cornea, and the lower eyelid does not cover any part of the cornea. In patient with hydrocephalus, due to compression of the center of gaze, the eye is displaced downward, so the upper eyelid does not cover any part of the cornea, and the lower eyelid cover one part of the cornea. There is very prominent scalp vein due to stretching of the scalp. There is various neurodevelopmental delay manifestations. The patient cannot sitting, standing, walking, crawling. There is also pyramidal tract signs. There is spasticity, clonus, Verisk reflexes, and Baminsky signs, usually extensor blunder. There is another ocular symptoms: obtuse nerve palsy, papillary edema, or optic atrophy in untreated cases. The mental retardation usually occur in chronic cases. This is the pictures for a patient having hydrocephalus. There is cephalofacial disproportion, appear as a small face, large sized head. The anterior fontanelle is wide, suture is separated, there is a squint, and there is sun setting appearance of the eye. What about the symptoms in children? The symptoms in the children after closure of the anterior fontanelle, there is raised intracranial pressure. So the patient complaining of headache, vomiting, blurring of vision, and squint. There is irritability, poor appetite, pyramidal tract signs and ocular signs, sleepiness, less ability to understand or lower cognitive. What about the diagnosis? Number one, in the history, you should research or you should ask for familial cases suggesting X-linked recessive aqueductal stenosis. The presence of prematurity in the perinatal history suggests this patient may be subjected to intracranial hemorrhage, and this is the cause of the hydrocephalus. The presence of seizures or feeding lethargy suggests infection. During the examination, don't forget to measure the head circumference, and there is progressive increase in the head circumference. Don't forget to examine the back for myelomeningocele in chiari malformation type 2. You may auscultate the skull. If there is EV malformation, you will hear el pirouet of the aneurysm. Fundus examination for chorioretinitis and papilledema. In the old past history, we usually use the torch to illuminate the eye. If the illumination is increased, so there is excessive dilatation of the ventricular system. Investigations. We should do firstly CT and MRI. So the CT and MRI showing dilatation of the ventricular system proximal to the site of obstruction. Cranial ultrasound show dilatations of the ventricular system. X-ray skull, there is an old, and we don't do this investigation. Before closure of the anterior fontanelle, there is separation of the suture, erosion of the crinoid process, and the increase in the convolutional marking, what's called beaten silver appearance. The treatment, number one, there is a medical treatment. We use a diuretics, example acetazolamide, from 14 to 75 milligram per kg per day to decrease the CSF formation. Surgical treatment, number one, repeated lumbar puncture for acute cases. If the patient comes in the acute stage and there is progressive increase in the head size and the patient is not suitable to do definitive surgery, we do repeated lumbar puncture to decrease the pressure inside the ventricular system to alleviate the symptoms until we can do the surgery. The definitive surgery is ventriculoperitoneal shunt or ventriculoatrial shunt or ventriculourethral shunt. Nowadays, the most common procedures is ventriculoperitoneal shunt. We may do endoscopy to treat multiloculated hydrocephalus, especially in infant above 6 months. Third, ventriculostomy based on the child anatomy and the age. Shunt complication, like any other surgical procedures, the patient may subjected to infections or malfunctioning of the shunt, or bleeding, fever, vomiting, irritability, swelling in the tube, or lethargy. Contraindications: arrested hydrocephalus. We means by arrested hydrocephalus there is no progressive increase in the head circumference or there is no progressive dilatation of the ventricular system by the radiological examination, so we cannot do the surgery because the body accustomed this high CSF formations and there is no progression. Severe mental retardation, severe motor retardation, lethal extracranial anomalies. The prognosis of the hydrocephalus: on the mental function, the intelligent quotient is decreased, a higher cortical function is affected, memory and judgment. There is a preserved speech. There is a visual problem like squint, decreased visual acuity, and optic atrophy. There is also accelerated puberty is common due to a stimulation of the pineal body. This is the procedures of the ventriculoperitoneal shunt. We open the skull, remove a flap from the skull, and then open the dura with the arachnoid motor, putting the shunt tube in the lateral ventricle, and then remove the shunt slowly, subcutaneous, head and neck, and then to the abdomen. We throw the tube inside the abdomen, and there is a valve behind the ear. Once the pressure increased in the lateral ventricle, the valve is open and the CSF escapes to the peritoneal cavity, and then the peritoneal this fluid will be absorbed from the peritoneal cavity through the peritoneal membrane to pass to the circulation again, and thus we decrease the pressure inside the ventricular system.